My talk is about complicated monochorionic pregnancy, atypical cases, and diagnostic errors. The rate of multiple pregnancies is increasing, and the complication rate of twins is also on the rise. The most unfavorable outcomes of the monochorionic pregnancy are double antenatal demise or death of one twin with a disability affecting the surviving one. The main types of complications of monochorionic pregnancies are three syndromes: fetal-fetal transfusion syndrome, TTTS, twin anemia polycythemia sequence TAPS, and selective fetal growth restriction. Their classifications are recognized in the perinatal world and published as IUGR guidelines. Typical TTTS, up to 10% of monochorionic twin pregnancies. The 5-stage sequence was described and classified by Quintero 25 years ago. Oligopolyhydramnios combination, OOP, is a reference symptom of all stages of this syndrome. For the diagnosis of the first Quintero stage of TTTS, we critically must see both the recipient's polyhydramnios and the donor's oligohydramnios. The quantitative criteria for OOP in the first Quintero stage were revised in 2017, and they depend on the gestational age factor. In the second Quintero stage of TTTS, there is a noticeable difference in the size of the twins' bladders. Usually, there is no image of full bladder of the donor twin. There is little or no amniotic fluid in the donor's amniotic sac. In such conditions, the donor is wrapped in his own amniotic membrane and looks stuck to the wall of the uterus. At the third Quintero stage, we record abnormal Doppler, absent or reverse diastolic blood flow of the donor's umbilical artery. Abnormal Doppler of the ductus venosus can be recorded in both the recipient and the donor, but the causes of impaired venous blood flow are different. The overload of the recipient's hypervolemia versus anemia and hypoxia of the donor's myocardium. Hydrops is a sign of the deterioration, the fourth Quintero stage. The severity of hydrops is variable, ranging from slight ascites to total edema and subcutaneous anasarca. There are two different cases here. In both, fetuses with edema died 24 hours after the registration of this sign. Typical TAPS, 3 to 13 monochorionic twin pregnancies. This syndrome also has 5 stages. In the first 2 stages, twins have Doppler velocity discordance in the middle cerebral arteries. At stages 3 and 4, the Doppler signs of cardiac compromise of the recipient manifests. Then his hydrops develops and the death of one or both fetuses occurs. An update was recently published to the IUGR TAPS criteria based on the Delphi consensus. These criteria are either deviation or intertwin discordance of the MSA, more than one mom. We record MCA discordance at all stages of TAPS. This looks like a significant difference in Doppler patterns. Starry sky sign. The recipient's liver has small areas of increased echogenicity. This sign has a high sensitivity in the diagnosis of polycythemia of the TAPS recipient. A typical case of TAPS. This was my first personal encounter with this syndrome. Placental dichotomy, no amniotic fluid discordancy, and skin color discordance at birth. At that time, we were not well aware of TAPS syndrome, first described in 2007, and did not have guidelines for routine MCA Doppler in monochorionic twins. Important to keep in mind, cardiac compromise of recipient twin is found in advanced stages 3 or 4 of both TTTS and TAPS. Ultrasound signs of the recipient's heart failure, cardiomegaly with a markedly increased cardiothoracic ratio, as well as symptoms of hypertrophic or dilated myocardiopathy. Doppler signs of recipient's cardiac compromise are not included in the Quintero system. Meanwhile, these are signs of a serious cardiac dysfunction, umbilical vein pulsation, tricuspid regurgitation, and monophasic atrioventricular flow. Typical selective fetal growth restriction up to 15% of monochorionic twin pregnancies. We define this syndrome as the weight or either twin less than 10th centile and intertwin weight discordance equal or greater than 25%. Eduardo Gratakas described 3 types of syndrome depending on the Doppler patterns of the smaller twins' umbilical artery. In this condition, we also often see discordance of the umbilical cords and velamentous cord insertion. Why can we be mistaken in the ultrasound diagnosis of twins complication? I distinguish 3 levels of operator's errors. The first level of error is in the detection of chronicity and amnionicity of multiple pregnancy. By the way, in the ultrasound reports, the frequency of incorrect detection of the type of multiple pregnancy reaches 27%, and this was discussed at the World FMF Congress in Lisbon. The second level of error is incorrect diagnosis of a typical syndrome. This level of errors is related to the competency of the sonologist. And the third level is error in detecting of an atypical syndrome, consists of a sequence of atypical chronology and unusual symptoms. Determination of amnionicity, mono or diamniotic twins. It is sometimes difficult to distinguish between diamniotic twins with ahydramnios of one twin and monoamniotic pregnancy. On this video, the amniotic membrane tightly wraps the twin. There is no fluid in his amnion, and his face features of these fetus become flattened. The profile of such a fetus is similar to a face in a stocking. These are diamniotic pregnancy, but one amniotic cavity is empty. Just the umbilical cord is visible in it. For the diagnosis of monoamniotic twins, we use indirect signs. Close-spaced twins are embracing. Twins are fighting. Umbilical cord insertions close located. Or 2 umbilical cords colliding. One placenta or 2 placentas, the answer to this question is sometimes even more difficult. Rare anomalies of multiple placentas and their clinical significance were studied by the Lisbeth-Levy's group, the placentation of twins is not necessarily just mono or di. There are unusual and weird options: bilobular monochorionic, dichorionic fused, partially monochorionic or partially monoamniotic. In such cases, it is impossible to accurately determine the type of chorionicity by ultrasound, and ultrasound monitoring reveals non-classical atypical sequences. Is it T or lambda? It is not always easy to distinguish between a T sign or black lambda and a white lambda sign. Sometimes 3D helps to find the lambda. T or lambda. A white lambda is a choriodecidual tissue between the leaves of amniotic membranes, a sign of dichorionic twins. But sometimes, as early as at the end of the first trimester, this tissue can regress, and the accuracy of the lambda sign decreases with the growth of pregnancy. Why we might be wrong with the diagnosis of classical typical TTTS? Looking at these twins, you can immediately think of the TTTS. This pregnant woman was referred to our center with suspected TTTS, but this is not it. Early fluid discordance up to 16 weeks is more often a consequence of membrane rupture or fetal abnormalities. And filled bladder of fetus is a sign that should help us exclude interfetal transfusion. Though, unfortunately, in the early second quinterus stage, bladder discordance may not be obvious, as well as stuck twin sign. In some cases, this is a bright, noticeable ultrasound sign, especially if the donor fetus is located on the anterior wall and has no fluid at all, like on the video on the left. But when the donor has fluid, or the donor is stuck not to the anterior but to the posterior wall of the uterus, we do not read this sign so easily and may miss it. And finally, why do we often make mistakes in detecting atypical syndromes? Because sometimes it is difficult or impossible to classify them. Let's consider what can prevent an experienced and attentive sonologist operator from correctly diagnosing a monochorionic complications. Superimposing of non-transfusional oligopolyhydramnios in fetal abnormalities or infectious fetopathy. Atypically early or late ultrasound onset, not isolated syndrome, non-quinterity TTTS chronology, or atypical TTTS scenarios. Monochorionic syndromes turned out not necessarily mutually exclusive of each other and can present together in any combination. They have overlapping ultrasound symptoms. 5 atypical TTTS scenarios were described in publication by Asma Khalil in 2022. I recommend looking into this work if you are not familiar with it yet. This is a well-illustrated and comprehensive analysis of atypical cases. Asma and her co-authors distinguish between TTTS with selective IUGR, TTTS with evidence of cardiac compromise without notable amniotic fluid discordance, TTTS with concomitant preoperative TAPS, monoamniotic twin pregnancy with TTTS, and TTTS with spontaneous septostomy and moderate fluid discordance. TTTS with selective FGR. Eduardo Gratakas stresses that selective FGR is not TTTS. However, the progression of selective IUGR to TTS occurs in 4 to 7%. The specific feature of this scenario is a long latency period from the time of diagnosis to deterioration. In selective IUGR without TTS, laser coagulation is not the method of choice. Concomitant selective IUGR worsens the results of laser treatment of TTS. And in the context of ultrasound, it is important that the symptoms of both syndromes overlap and their differential diagnosis is often accompanied by confusion. In regard to TTS with anemia polycythemia, there are very little publications on such a continuum. I found only a few. 2 to 15 TTS twins present with anemia polycythemia before laser surgery. Approximately half cases had placental and skin color findings, typically reported with isolated taps. This combination is characterized by a later time of onset of the disease and more favorable outcome. It seems that with the help of the publications mentioned above, we are beginning to get closer to unraveling an tangle of intertwined symptoms and reclassifying the complications of monochorionicity. Let me present you a small collection, a series of cases from the ultrasound archives of UZ schools. This series was collected at the Kharkiv Regional Perinatal Center. Case 1. A complication of this monochorionic twin pregnancy was diagnosed at 26 gestational weeks when the woman began to have pain. Before that, the pregnancy was monitored in the other centers, and at 20 gestational weeks, everything seemed to be perfect. We saw fluid discordance of 16 cm to 0, as well as MCA discordance, and estimated fetal weight discordance of 25%. The donor fetus had absent diastolic umbilical artery flow, and the recipient had signs of severe cardiac compromise. His cardiovascular profile was reduced to 3 points out of 10 possible, and he also had a starry sky sign. Caesarean section was performed, and the newborns had hemoglobin and skin coloration discordance. The smaller twin was extracted in the sac, and his pale skin coloration is poorly visible in this photo. The outcome of this case was unfavorable, and case can be classified as TTS Kintero 3 plus TAP3 and plus selective IUGR of the second type. Case 2. Diagnosis at 28 weeks. The discordance of MCA in twins was combined with fluid discordance 12 cm to 3 cm and filled bladders of both fetuses. Hence, there were no criteria for TTS. There was a normal donor's umbilical artery Doppler and a recognizable starry sky pattern in recipient's liver. We diagnosed this anomaly at the stage of critical impairment of the recipient's cardiovascular profile. Ductus venosus, reverse blood flow, triphasic pulsation of the umbilical vein, tricuspid regurgitation, and increased cardiothoracic ratio. Pay attention in this video. 2 hearts pulsate side by side. Impaired contractility of the myocardium of the heart on the left is determined by eye and objectified by calculating the ejection fraction. There was an emergency caesarean section, extraction of twins in the amniotic membranes. The difference of skin of newborns is clearly visible, and this case has been classified as TEPS 3 plus polyhydramnios. Case 3. Initial diagnosis at 26 weeks. Again, amniotic fluid 10 cm to 0. The donor fixed at the lateral wall of the uterus, and his profile is in a stocking, and the recipient with a starry scar liver. The next day, an abnormal Doppler appeared, which meant the progress of stage Kintera 2 to stage 3. Marked hematological discrepancy at birth, hemoglobin 18 to 11. Here in the photo, an ex-donor in his third day of life after hemotransfusion with hemoglobin 14, but the difference in skin coloration is noticeable here. This atypical transfusion is classified as TTTS Kintera 3 plus TAPS. Case 4. The diagnosis of TTTS was established at 18 gestational weeks. Amniotic fluid 2 to 6 cm. Small fetus without bladder. Weight discrepancy of 35%. The membrane vessels of the smaller fetus were noticeable. And a few days later, in another center, the TTTS was cancelled in favor of the diagnosis of type 2 selective IUGR. Further, for several months, the woman was not available for control, and at 34 weeks she was referred to our center again, but with serious deterioration, and not a lesser but a greater fetus. He was with signs of severe cardiac compromise. The children had a discordance of weight as well as hemoglobin. Also, visually, the color of the skin was almost the same. The larger twin was born with heart failure and hepatomegaly. He lived just 1 day. The diagnosis at autopsy was hypertrophic cardiomyopathy. I thought a lot about that case. For a long time, I did not understand how to explain it. And I came up with this idea of classification. Selective IUGR 2, TTTS not Kintera sequence, and recipient's cardiac compromise. Case 5. At 20 weeks, 50% weight discordance, selective IUGR type 2, amniotic fluid 7 to 3 cm. But the next day, the twins' amniotic fluid values changed to 8 and 1 cm, and the smaller one's bladder disappeared. Hence, as soon as 24 hours later, there was a fast progress of selective IUGR into the TTTS. This case ended in early premature labor. Case 6. Another scenario of interfetal transfusion. No prenatal finds. At birth, skin color discordance. Acute peripartum TTTS is a rare and unexpected form of circulatory imbalance in monochorionic twins. And case 7. Another confusing one. Diagnosis at 31 weeks. Weight discordance was of 34%. Selective IUGR type 3. Intermittent umbilical Doppler of the smaller fetus. The fluid difference was significant, 3 to 14 centimeters. Thick placenta and thin amniotic bands. No MCA discordancy. The bigger fetus was large for gestational age with cardiomegaly, myocardial hypertrophy, and hepatomegaly. It turned out to be a selective IUGR 3 with comorbidity with infectious fetopathy, with congenital pneumonia of the bigger twin. By the way, doesn't this liver remind you of the starry sky? It seemed to me like a starry sky pattern, and it's confused the prenatal diagnostic process. Meanwhile, starry sky appearance is a non-specific sign that is encountered in many entities, including acute hepatitis and some other reasons. Here is the list of them. So today we tried to untangle this tangle but it looks as we did not completely cope with this task. Try to diagnose yourself these twins from the famous painting. And in the meantime, I will tell you the story of the diagnosis of a multiple pregnancy. It was one after the use of RRT. 2 embryos were transferred. 1 embryo vanished. 1 embryo left. Then it split. Now there were 2 embryos. Then another embryo split, and now there were 3 embryos. So the family received 3 ultrasound reports with a different number of twins. It was dichorionic triplet, a completely different story, and this family allowed me to post this video in this lecture. So sometimes it's hard to count them. Take home, please. Monochorionic complicated twins require frequent ultrasound monitoring. The progress of symptoms and the deterioration lasts during 1 day to several months. OB/GYN and perinatal centers should be aware of the complexity of the prenatal differential diagnosis of monochorionic pregnancy complications. The Starry-Sky sign works for the diagnosis of polycythemia but has limited specificity. The 5 scenarios described in work of Khalil explain the atypical chronology of transfusions. Perhaps there are more than 5 scenarios, and classifications may be reviewed in the future. Sonologist trainings are necessary to reduce operators' first-level diagnostic errors. UZ School is made in Ukraine. You can scan QR codes and follow us on social media. We have daily updates of interesting ultrasound cases for you. This is my valuable collection. For many years in a row, I have been receiving photos of these twin girls. I have kind permission from the family to display these photographs in this lecture for doctors from different countries. A successful result of such a pregnancy is possible only if the diagnosis is successful. In a case like this, ultrasound saves lives, and this is absolutely not an exaggeration. Thank you very much for your attention.